Dear friends, down the series, we are going to visit Modifier 25 today. This is the most commonly used modifier along with an E&M service, which is Evaluation and Management Service. This modifier is not used for the surgical procedures. It is purely for the EM codes, the E&M codes. Now, if you happen to see a claim in which there is an E&M service and then any procedure, whether it is a service or a procedure, then you will have to assign Modify 25, otherwise the claim will not pass the payer edits and it can be denied upfront. Many billing companies employ medical billers and medical coders, but if you happen to visit some companies, there you may not find medical coders, but it is a medical billers who actually move the claims. Because they do the superable coding and the management feels that a coder is not needed. But care must be ensured even with the superable coding or with cheat sheets, though the provider has selected the codes, that should be supported with the medical documentation. In case of audits, we need to submit such substantiating proofs as documentation. We need to have those substantiating documentation as proof for billing this particular service. Well, today we'll talk about Modifier 25. This would go a little lengthy, so I've planned to divide into two parts. Now let's see the first portion of this Modifier 25. I have witnessed in companies where a medical biller, what he does is, if there is a claim with an E&M code and a procedure, he might be working on a denial in which you find that Modifier 25 was not being assigned initially. So what he does is, he comfortably assigns Modifier 25 and then sends the claim for resubmission. Again, you see, the claim would be denied. The claim would come back to the analyst stating its denial, then the analyst would send the claim back to the where this same biller would assign another modifier 59 to the procedure code and then he would send it. Now this time also the claim would be denied. Now third time when the claim comes back, he doesn't know how to handle it. So he keeps the claim in the AR backlog and then that will be addressed separately by a different team, especially the coding team. But if you peruse and if you analyze this particular claim along with this medical records, there wouldn't have been any need to assign modifiers because the E&M code in the first place shouldn't have been built. You see, this is a plight of medical billing companies and of course bigger MNCs where denials are being worked haphazardly by some of those ignorant medical billers and medical coders. They keep trying whether to use this modifier in the first place and they'll use the second modifier in the second place, and sometimes who knows if he's going to be a fresher. I'm not just talking about a medical biller. When I say a medical biller, he can also be a medical coder. Please understand. So this billing and coding are being used interchangeably sometimes. If you're going to work in the United States, you are not going to be differentiated. A coder will have to do a billing work and a biller would also have to do a coding task. But in India, we have divided into two separate categories just for the sake of convenience and for productivity and quality purposes. Many a times, claims with 25 will not warrant a separate reporting with an EM code. Medical auditors are now conducting vigorous audits to ensure if this Modifier 25 is not being abused. I can say the commonly abused modifier is Modifier 25 and Modifier 59. Now let's go to the characteristics as to when we can assign a Modifier 25. If you see the description of Modifier 25, it says significant, separately identifiable, evaluation and management service by the same physician on the same day of the procedure or other service. You need to give attention to each of those words which is being mentioned under this modifier because it says significant and separately identifiable. Now, how are you going to define the word significant? When does the evaluation and management service becomes significant? Now, this is a lacuna in medical coding because neither doctors understand it properly nor coders understand it properly. I'm not saying all the coders, but some of the medical coders. There have been significant reporting and rampantly abusing of this Modifier 25 because I've also seen doctors and nurse practitioners, they believe that whenever there is an office visit, whenever the patient comes and sees a doctor, they're under the impression that the E&M service should be reported. And if they happen to perform any other procedure or any other service, then they would report Modifier 25 unhesitatingly to the E&M service or the consultation service which they render. But we need to really understand this burning issue of reporting Modifier 25 unnecessarily. The modifier description states as significant. If a provider happens to do an E&M service and a procedure on the same day, now here the doctor will have to ensure that the E&M service which he does should be a significant service. Now, why does this point arise here? Because when a doctor is going to do a procedure, now every procedure will have a certain pre-E&M service and then a post-E&M service, which means a procedure already includes an evaluation and management service. Immediately you can't do a procedure. You need to prepare the patient. If there's going to be a major surgery, definitely there needs to be a pre-operative phase. There are certain surgeries which are done under emergency situations, but for routine and planned procedures, we need to understand that every such procedure includes a portion of the evaluation and management service. It is a duty of this medical coder to identify which service the provider has done. Is this significantly identifiable? Because the procedure bundles the E&M service. As you see, the E&M service should be over and beyond the procedure. When a doctor does a procedure, he is going to do a basic examination. This basic examination is included in the E&M service. Then how are you going to separate this procedure from the E&M service? And another misconception among coders is that whenever a new patient comes and a procedure is being done, we need to report the E&M service. That's not always true. Again, it should qualify for the characteristics of this Modifier 25. Now see the terms separately identifiable. How significant the E&M service is, it is a duty of the doctors to document it. They will have to provide the substantiating documentation and state that the E&M service was definitely significant. If the coder is not convinced, he should ask the doctor for clarification, because this claim, if it is going to be audited by any medical auditor tomorrow or by any payer or any agencies tomorrow, it should stand trial in a court of law. You can also query the physician or the nurse practitioner if you really want this E&M service to be billed, because you're going to charge for this consultation service and you're going to bill for the procedure. Now let's have a look at the words separately identifiable. The E&M service should be identified separately. So sometimes doctors provide a separate note for E&M and a separate procedure note. But in case of minor procedures or minor surgeries, you don't have to have a formal procedure note. The procedure note can be very well included within the documentation of the E&M service itself. You don't have to have a separate note for the procedure, especially for minor procedures. There can be different conditions for E&M service and procedure, but it is not mandatory. Sometimes payers expect that you should have separate conditions. The EM service should have a separate diagnosis code, and the procedure or surgery should have a separate diagnosis code. Now, if you have in a medical record separate conditions, a condition A has been evaluated by the physician, and for condition B, the surgery has been done, then there is no problem on the part of this medical coder to report both the EM service and the procedure codes with the appropriate diagnosis codes. But still, the physician will need to ensure that he places the accurate documentation, in the absence of which reporting an EM service with Modifier 25 is not justifiable. Well, if the patient presents with the different conditions and evaluation for one condition has been done and a procedure for the other condition has been done, it's good, and this claim can certainly pass an audit, and we can certainly defend this claim. But sometimes patients might visit for a chief complaint, and the physician might also do a procedural service addressing the same chief complaint, but then the EM service would have been significant. In that case, you will have to report only the same diagnosis code for both the procedure and for the EM service. Now, during such times, it becomes critical for the medical coder to express to the insurance company that the physician's service was extraordinary. Sometimes there could be paid frequencies as well in the reporting of those EM codes. This modifier is used in conditions where the procedure or the service and the EM service has been done by the same physician on the same date of service. If the physician is going to do a procedure on one day and the E&M service on the other day, then the question of this modifier does not come into picture. So for this purpose, sometimes some providers might schedule a procedure the next day or the successive day so that they think that can evade the audit risks. Care must be taken as Modifier 25 should not be used without justification. There have been excessive usage of Modifier 25, which means that the EM coder is not thorough with his coding concepts. Only when there is a significant and a separately identifiable service, we can report this EM code. When you review the medical record, you find that there is no justification for reporting the EM code, but I see from the medical billing departments and of course the medical coders would comfortably report Modifier 25 with the EM codes. And when we are going to report the EM codes, please ensure that this code accurately reflects the extent of examination, the extent of history taking, and the degree of medical decision making that has been done by this provider. I hope this small session would have helped you to understand the scenarios as to when we should report Modifier 25. And we will see the risks associated with. I'll present an example and explain to you as which is an appropriate strategy to report Modifier 25. I'll see you in the next video, and thank you very much for watching this.